1 in 5 patients diagnosed with TB in Uganda are not initiated on TB treatment within 2 weeks of diagnosis. This phenomenon is often referred to as pre-treatment loss to follow-up and leads to high rates of mortality. Previous studies have shown that patients who experience pre-treatment loss to follow-up have a 3-fold increase in mortality compared to patients who are successfully initiated on treatment. In order to meet the end TB target, to reduce TB-associated mortality by 95% over the next 15 years, we must improve treatment initiation among patients diagnosed with TB. We evaluated a multi-component intervention for improving TB treatment initiation among patients diagnosed with TB using Xpert testing. This was a single-arm intervention trial using a pre- and post design at 1 tertiary referral hospital. The intervention was developed and refined through formative work informed by the behavior change wheel and the COMB model. The main intervention functions included education, environmental restructuring, and enablement. For education, we carried out CMEs at the hospital to improve healthcare worker knowledge about the magnitude of pre-treatment loss to follow-up at their hospital. For environmental restructuring, we modified laboratory request forms to improve recording of patient demographic information such that we could follow up patients who do not initiate treatment. We also redesigned the workflow processes to improve timeliness of sputum testing and results dissemination. For enablement, we provided desk phones to improve communication of results between the lab and the outpatient department, and between the outpatient department and the patients. We collected process and outcome data related to TB diagnostic evaluation for the period before the intervention, June to August 2019, and the period after the intervention. We collected data on three main outcomes: patient locator recording using our modified laboratory request forms, sputum turnaround time, and TB treatment initiation. In September 2019, we held 4 CME sessions attended by 58 healthcare workers. In the 3 months following the introduction of these interventions, we saw an improvement in recording of patient phone numbers on laboratory request forms. Before the intervention, only 46% of patients had a phone number recorded on their lab request forms. After the intervention, this proportion increased to 60.3. The proportion who had a full address, including the village, did not improve significantly. This was probably because the healthcare workers focused on getting a phone number in order to communicate results via the phone. The proportion of patients who had a sputum test result relayed to them within 12 hours of reporting to the health facility improved from 45% to 98%. During the intervention, none of the patients took more than 24 hours without receiving a sputum test result. The median turnaround time improved from 12 hours with an interquartile range of 4 to 46 hours to 4 hours with an interquartile range of 3 to 6 hours. Treatment initiation markedly improved. The proportion of patients who had a same-day diagnosis improved from 7.4% to 25% after the intervention. And the proportion of patients who are not initiated on TB treatment decreased from 29% to 9%. Our multifaceted intervention was feasible to implement and was associated with improved TB treatment initiation among patients diagnosed with TB at Jinja Regional Referral Hospital.